am Professor Patrick.
Professor?
Dr. Professor Patrick.
Welcome back. We're going to be going through the neurology and rheumatology sections. Some of the learning objectives are to diagnose and manage brain infarctions and bleeds, to analyze the causes of movement disorders, to differentiate the presentations of dementia, to identify spinal cord injuries by history and physical exam findings, and then to contrast headache causes and stratify their management, to identify common neurologic pathways by radiology. We're going to start out with strokes. So a 71-year-old woman awakens with the inability to move her right arm and facial droop. Her speech is incomprehensible to her husband. She has no history of hypertension, hyperlipidemia, diabetes, or smoking. On exam, her blood pressure is 128/78. Her heart rate is 123 and irregularly irregular. So it seems like the cause of this might be an AFib. Next best step would be a head CT. And MRI is more sensitive, but it takes longer to result. The reason you do the head CT first is to see if there's any head trauma or reasons that you would not be able to give clot-busting drugs. The next steps are to determine the causes. So EKG, carotid duplex, transesophageal echoes, and MRAs are all used. Some of the causes are thrombotic, so you think hypertension, hyperlipidemia, diabetes, and smoking. Lacunar infarcts, think mini strokes from hypertension, or embolic due to AFib, mitral regurg, or paradoxical emboli from DVTs. So kind of the symptoms to look for depending on the location. If it's an anterior cerebral artery, you want to look for contralateral leg weakness. If it's all sensory loss, you want to look at the thalamus. If it's all motor loss, you want to look at the internal capsule. If there's hemineglect, look at the non-dominant parietal lobe. If there is word salad or Wernicke's encephalopathy, it's often the temporal lobe. And then Broca's aphasia is often the frontal lobe. They can't form the words. They have a broken Broca. Blindness is usually due to a PCA, and you get homoenepeus hemianopsia. The treatment is going to be thrombolytics within the first 4.5 hours, or thrombectomy if it can be performed. If you're outside the window, you can only give supportive care, blood pressure control, and secondary prevention measures by trying to determine the cause and prevent a future stroke. Some brain bleeds. We've got a 58-year-old cocaine user who presents with a thunderclap headache that is the worst of her life. She's nauseous and lethargic. On exam, her blood pressure is 220/123, and she's unable to raise her left arm. So this can be a subarachnoid hemorrhage. You can confirm with a head CT, or you can do a lumbar puncture and look for xanthochromia in the CHF. Treatment would be surgical clipping and blood pressure control, and then you want to do nifedipine to prevent any vascular spasms. Next, we've got a 23-year-old basketball player who strikes his head against the backboard. He regains consciousness after about 30 seconds and asks his coach to go back in the game. He appears disoriented and complains of headache and nausea. On exam, one pupil is large and unresponsive to light, and CT scan shows a lens-shaped biconcave bleed that does not cross the suture lines. So this would be typical of an epidural hematoma. You would need to evacuate the hematoma and treat the ICP. Next, there's a 65-year-old alcoholic who presents after falling off a curb and striking his head. He's inebriated and uncooperative on exam. CT scan shows a crescent-shaped concave hyperintensity. And this is a subdural hematoma. It's especially common in alcoholics due to their increased risk of bleeding and also the brain atrophy, especially in elderly. And you want to evacuate these hematomas and treat the ICP as well. Moving into movement disorders for Parkinson's disease, this case is a 59-year-old man presenting with his wife for recurrent falls. His wife expresses he won't pick up his feet and he keeps shuffling with poor posture. The patient speaks softly with little expression, and on exam there is rigid initiating movements and a slow tremor is visible in his hand. So there are some variable presentations of Parkinson's disease. There's the Sjogren, or Parkinsonism with autonomic instability, like orthostatic hypotension. There's progressive supranuclear palsy, which you would look for Parkinsonism in an older man with no tremor. And then there's Lewy body dementia, where dementia occurs within 1 year of Parkinson's symptoms or before. For the treatment, you want to do carbidopa levodopa is the mainstay, which can cause GI effects and hallucinations. Eventually, this has a decreasing therapeutic window as more of those neurons are lost, and it causes on-off events where all of a sudden they regain function, and then the therapeutic window closes and they lose function again. You can also use dopamine agonists like pramipexole, selegiline, which is a monoamine oxidase B inhibitor, amantadine, which was formerly an influenza medication, which watch out for side effects like livedo reticularis, and then anticholinergics like trihexyphenidyl and benztropine can counteract some of the tremulousness from having too much acetylcholine and not enough dopamine. More movement disorders. There's a 36-year-old who presents for increased clumsiness and a change in mood to his PCP. His family history of suicide in his father at 40. MRI shows degeneration of the caudate nucleus. So this would be a Huntington's chorea. It's caused by an autosomal dominant CAG trinucleotide repeat on chromosome 4. You can only treat the anxiety and depression, and this often exhibits anticipation, or it increases the likelihood of presenting earlier with each generation. Next, there's a 54-year-old watchmaker who presents for a tremor that is worse when he's concentrating. His mother had a similar tremor and improves when he takes a drink of alcohol. So this would be an essential tremor. You can treat these with propranolol or barbiturates. Lastly, there's a 20-year-old who presents with the uncontrollable urge to clear his throat, blink, and grimace. This would be Tourette's syndrome. You have to have at least one motor and one phonic tic, and you can treat this with clonidine, haloperidol, or primazone. Next, there's dementia. So an 84-year-old presents with his family for increasing episodes of getting lost around town. He recently moved in with his children's home due to leaving the stove on and being unable to manage his bills. Diagnosis of dementia, you want to follow up with a workup to look at reversible causes like electrolyte disturbances, hypothyroidism, depression, anemia, syphilis, HIV, or brain lesions. And some of the common causes of dementia, Alzheimer's being the most common. Age is the largest risk factor. It's got a slow progression, and it often presents with temporal lobe abnormalities like getting lost and forgetting things. Next up would be vascular dementia, which is caused by hypertension, hyperlipidemia, and smokers. And this is more of a stepwise progression. On CT scan, you would see lacunar strokes or small lakes. Next is normal pressure hydrocephalus. This is the classic triad of wet, wacky, and wild. And on CT, you would see enlargement of the ventricles. Next is Lewy body dementia, which is often presenting around or before Parkinsonian symptoms, and it's dominated by psychiatric disturbances like Capgras syndrome, where you think your loved ones are replaced by imposters. And then the most advanced would be Creutzfeldt-Jacobs disease. It's a prion disease, and it's marked by young, rapidly progressing dementia. So think somebody 40s to 50s with rapid progressing within 2 to 3 months. And on EEG, there's a classical 3-spike and Hertz pattern. The treatment for all of these would be supportive care. You can try a trial of cholinesterase inhibitors like donepezil, rivastigmine, or galantamine for Alzheimer's disease, and you want to avoid anticholinergic medications. Next is multiple sclerosis. We've got a case of a 27-year-old Caucasian woman with left arm weakness and painful alterations in vision. 6 months ago, she had leg numbness that gradually resolved. On exam, there's intranuclear ophthalmoplegia is found. On CT scan, there's multiple hyperintensities at differing stages. So this is classic for multiple sclerosis. You can do a lumbar puncture looking for oligoclonal bands, and you can treat acute episodes with IV steroids. And the goal would be to prevent flares in a progressive patient with glantamine acetate, natalizumab, or ocrelizumab. Next, there's a 37-year-old who presents with leg numbness and difficulty ambulating 2 weeks after a stomach flu. On exam, bilateral patellar and ankle reflexes are absent. Lumbar puncture shows elevated protein but normal cell counts. Diagnosis would be Guillain-Barré syndrome. You want to watch for respiratory depression as this ascending paralysis presents. You want to treat with IVIG or plasmapheresis, not steroids in this case. In the last case, we've got a 57-year-old who presents to the ED with left-sided facial droop. A code stroke is called. On exam, the patient has 5 out of 5 strength in all limbs, and the facial droop that does not spare the forehead. So this is classic for Bell's palsy compared to a stroke. It's loosely associated with viral illnesses in URIs, or also herpes simplex and herpes zoster. You want to treat with steroids, and you want to look at eye precautions. If they're unable to close their eye completely, they'll need artificial tears. Next case, we've got a 27-year-old woman presenting with fatigue and weakness. She works on the computer and notices difficulty keeping her eyes open and typing later in the day. On exam, there's prolonged upward gaze is limited by ptosis, and proximal musculature is 4 out of 5 on repeat testing. So an EMG shows decremental response to repetitive stimuli of the motor nerves, and this is diagnostic for myasthenia gravis. You would want to do a CT of the chest to rule out a thymoma, which can cause a paraneoplastic MG, and you want to observe for respiratory collapse. You can treat this with acetylcholinesterase inhibitors, anything that ends in a stigma, or immunosuppressive drugs, while the exacerbations are treated with plasmapheresis. Next, we've got a case of a 59-year-old man who presents with progressive muscle weakness in his arms and tongue. There is no pain or sensory loss. On exam, his brachioradialis reflex is spastic, and tongue fasciculations are appreciated, so they're both upper and lower motor neuron lesions, and there is no sensory loss. So this would be diagnostic for ALS. This disease has a progressive course, and you can try a trial of Riluzuz. Next is spinal cord diseases. A 37-year-old man presents after he burned his hand on an oven. He denied knowing the stove was on. 6 months ago, he was involved in a motor vehicle accident and suffered from whiplash. On exam, he has pain and temperature sensation loss in a cape-like distribution. So this is a stringomyelia. It can be confirmed with an MRI. It's the interior of the cord. That's why it's upper lesions, and it's pain and temperature sensations. Next, there's a 18-year-old who was stabbed in the back during a gang fight. On exam, he has ipsilateral paralysis and loss of vibration and proprioception, and there's a contralateral loss of pain and temperature. This diagnosis would be Brown-Sequard syndrome. So depending on where the decussation is why you have ipsa and contralateral loss of pain versus vibration proprioception. Next, there's a 23-year-old woman who presents with leg weakness, pain, and palpable bladder on exam. MRI shows hyperintensities within the thoracic cord. So this is transverse myelitis. Think of this like MS of the spinal cord. You can treat this with IV corticosteroids. Next is a 45-year-old IV drug user who presents with sudden onset shooting left leg pain. On exam, she is hyporeflexic with saddle anesthesia. So this can be cauda equina syndrome, and emergently you need an MRI and a surgical evaluation. Next is a 58-year-old construction worker who presents with sudden onset back pain and urinary incontinence. Exam shows perianal anesthesia and symmetrical hyperreflexia, and this would be conus medullaris syndrome, and you want to treat this with emergent MRI and surgical eval as well. Moving into headaches, this case is a 32-year-old woman presenting with intense one-sided headache that is exacerbated by light and sound. She's complaining of nausea. This is classic for a migraine headache. You can treat these with any of the triptans and also antiemetics if needed. Some of the prophylaxis for this would be TCAs, beta blockers, or calcium channel blockers. Next is a 25-year-old man who presents with acute, severe headache that feels like they're being stabbed in the eye. On exam, there's conjunctival injection, miosis, and lacrimation. This is classic of a cluster headache. You can treat this with inhaled oxygen or some of the triptan medications, and you want to prophylax this with calcium channel blockers or treat it with indomethacin. Next is a 25-year-old medical student who presents with a headache in a band-like distribution before finals. It does not wake him from sleep, cause emesis, or have associated focal neurological deficits. This is classic of a tension headache. There's no red flag signs. You want to treat this with NSAIDs, sleep, and stress relief. Last, there's a 36-year-old woman with PCOS that's on Accutane who presents with a dull headache that's worse in the back of the head. The pain is worse when she bends forward, and on exam papilledema is seen. So this is IIH, or idiopathic intracranial hypertension. You can treat this with acetazolamide, weight loss, and lower vitamin A, You can also do serial LPs if it does not resolve. And the worrisome finding here is that you can get progressive bitemporal hemianopsial blindness from this. Moving into meningitis, there's an 18-year-old college freshman who experiences a headache and photophobia before going to sleep. He wakes up nauseous with persistent headache and neck stiffness. His vital signs are hypotensive with tachycardia. On exam, there's considerable neck stiffness with a positive Babinski and Koenig sign, as well as petechial rash. Next step would be a lumbar puncture with cell counts and gram stain. For bacterial meningitis, you're looking for high WBCs with neutrophils, high protein and low glucose. For aseptic or viral meningitis, look for normal to high WBCs with lymphocytes and high protein with normal glucose. And any fungal or TB meningitis, you want to look at high WBCs with lymphocytes, high protein count, and low glucose. The treatment is depending on age and the likely causal agent. If these are neonates, the most likely agents are GBS, E. coli, and Listeria. So you treat empirically with ampicillin and gentamicin. Depending on when they were born, you can consider third or fourth generation cephalosporins. For teens and adults, you want to treat for Neisseria meningitidis first, strep pneumo or H. flu, and you want to treat with ceftriaxone and vancomycin. And then in the elderly, strep pneumo is the most common, but Listeria comes into the picture again. So you treat with ceftriaxone, vancomycin, and you add ampicillin. Moving into some brain imaging here, there's an ischemic stroke, which you can see with the difference between the gray matter on the left, and then an intracranial hemorrhage on the right. An epidermal hematoma, or the biconcave lens-shaped, versus a subdural hematoma, which is the long crescent-shaped. Parkinson's disease, where you get degradation of the substantia nigra, versus Huntington's disease, where it's loss of the caudate nucleus. There's increasing hydrocephalus here, so this could be due to NPH or obstructive hydrocephalus. Multiple sclerosis has multiple hyperintensities found on MRI, and if you look coming off of the corpus callosum, you can see Dawson's fingers. Now we're going to start on rheumatology and musculoskeletal. The learning objectives here are to construct a management plan for connective tissue diseases, to contrast the presentations of inflammatory myopathies, to outline the presentation and complications of RA, to analyze synovial fluid aspirates of joints, and break down the common joint pains by location, physical exam signs, and identify axial pathology by radiographs. We'll start out with SLE. So we've got a 35-year-old woman who presents with fever, malaise, and joint pain. She's not been acting herself at work lately, and on exam there's a macular rash seen along the malar region, sparing the nasolabial folds. The next best step would be an ANA screening. Anti-double-stranded DNA or anti-Smith is very specific for lupus, but any ANA could be positive. And diagnosis now requires the SLIC criteria, so you need greater than 4 criteria met with at least one clinical and at least one immunologic criteria. Some of the clinical criteria are malar or discoid rashes, oral ulcers, alopecia, serositis, renal disease, neurologic disease, anemia, leukopenia, or thrombocytopenia. And then some of the immunological criteria are ANA, anti-double-stranded DNA, anti-Smith, anti-phospholipid, low complement, or direct COMLEX. And for drug-induced lupus, you want to specifically look for antihistone antibodies and discontinue. The most common culprits are procainamide, hydralazine, or quinidine. And then the treatment for SLE would be steroids for acute flares and immunomodulators for chronic prevention. Hydroxychloroquine is the best first-line medication, but you have to have yearly retinal toxicity screening. NSAIDs are the best for joint pain, but you have to be aware of lupus nephritis as this could worsen it. And cyclophosphamide is best for renal involvement. Next is scleroderma. We've got a case of a 45-year-old woman who presents with painful episodes in her fingers where they change color in response to the cold. She began wearing gloves in the supermarket. And she has a long history of GERD not well controlled with H2 and proton pump inhibitors. On exam, there is skin tightening around the fingertips with calcification and necrosis. And on exam, the nail beds show telangiectasias. The next best step here would be another ANA screen Specifically, the anti-centromere antibody is common in the limited or CREST form, and anti-topoisomerase or SCL70 is specific for the diffuse form. Screening barium swallow and pulmonary function tests are monitoring for complications. And the treatment, there's no effective cure, but you want to treat the different symptoms. NSAIDs are great for contracture pain, and you want to monitor the digit necrosis for osteonecrosis. H2 blockers and PPIs are used for esophageal dysmotility and GERD. Calcium channel blockers are used for Raynaud's. Bosentan is used for pulmonary hypertension, and cyclophosphamide for pulmonary fibrosis. And ACE inhibitors are used for renal disease and hypertensive crises. Moving into the inflammatory myopathies, we've got a case of a 56-year-old woman who presents for weakness over the past 3 months. She's had difficulty climbing stairs and reaching boxes above her head. On exam, her shoulder and hip musculature is 4 out of 5 with little pain. There is also a scaly erythematous rash on the PIP and MCB joints of the hands, Goiten's papules. And then CK, LDH, aldolase, AST, and ALT are all elevated. The next best step here would be ANA, specifically the anti-Jo1 or MI2 antibodies. EMG and muscle biopsies can confirm the inflammatory myopathy. You're going to look for perimesial and perivascular and endomesial inflammation. There's an increased risk of malignancy, specifically in the breast, lungs, ovarian, and GI, so age-appropriate screening is often an answer choice. And then the skin manifestations of dermatomyositis in particular. There's the heliotrope rash, which is a purplish lilac or red patches on the eyes, nose, and cheek. There's the Goitron papules, which are papular erythematous scaly lesion over the knuckles. And the Schall sign, or scaly rash and photosensitivity on the anterior chest, shoulders, upper back, elbows, and knees. With both of these, you would treat with steroids and immunosuppressive agents like methotrexate and cyclophosphamide. Some other myopathies, we've got a case of a 67-year-old man with weakness. He's been growing weaker over the past 3 years and requires a walker for ambulation. He's also had hand weakness that can lead to no longer holding a mug of coffee in the morning. His CK is mildly elevated. This is common of inclusion body myositis, which is usually older males, and it's distal hand weakness and proximal leg weakness. You can confirm this with a muscle biopsy. Next is a 71-year-old woman who presents with hip and shoulder pain. She's considerably stiff in the morning, but movement aggravates her pain. She feels melancholic and feverish, and on exam she has a temperature of 38.2. So this is polymyositis. The next best test would be an ESR, and you want to treat this with steroids and monitoring for signs of giant cell temporal arteritis. Moving into RA, or rheumatoid arthritis, a 37-year-old woman presents with joint pain, swelling, and weight loss. Her pain is worse in the morning, and she remains stiff until about midday. On exam, her PIP and MCP joints are markedly tender with synovitis. There's ulnar deviation and swan neck contractures. The next best step would be to order a rheumatoid factor and anti-CP antibody. ESRs and CRP are likely elevated, as well as anemia of chronic disease. You can do MRIs or radiographs to show the periarticular osteopenia, narrowing of the joint space, and bony erosions. The treatment would be steroids and acute flares, but the mainstay is NSAIDs and DMARDs. Methotrexate is the best initial DMARD, but you have to watch for GI upset, liver toxicity, pulmonary fibrosis, and bone marrow suppression. Next up, you can try lufenide, hydroxychloroquine, sulfasalazine, and alternatives. And then anti-TNF agents like infliximab, ernastacept, and second-line agents. So watch for reactivation of TB with those. Sjogren syndromes and extra-articular manifestations. So RA can lead to pathologies outside the axial system. In the skin, you can see rheumatoid nodules, which are painful subcutaneous nodules on the elbow or sacrum. In the lungs, you can have pleural effusions, very low glucose, and pulmonary fibrosis. Kaplan syndrome is an acute presentation of RA and pneumoconiosis. In the heart, pericarditis leading to restrictive carditis and pericardial effusions. CAD is actually the leading cause of death in RA, and it's thought to be due to long-standing inflammation. In the blood, there's anemia of chronic disease or hemolytic anemia, thrombocytopenia, and neutropenia. So another syndrome to know for RA is Felty syndrome. It's a triad of RA, neutropenia, and splenomegaly. So vasculitis, there's a relation to polyarteritis nodosum, and it can infarct areas of the body, leading to mononeurotic multiplex. In the spine, there's increased risk of atlantoaxial instability, along with Down syndrome. You have to screen with an X-ray before you do any type of intubation. And then we've got a case of a 32-year-old woman presenting for itchy, sandy feeling in her eyes for 2 months, along with difficulty chewing her food. Filter paper is placed near the lacrimal ducts and measured the tear duct output, or Schirmer's test. Diagnosis would be Sjogren syndrome. You can screen with ANA, specifically the anti-Ro and La antibodies. You can treat with pilocarpine, artificial tears, and good oral hygiene. Secondary Sjogren's is related to connective tissue diseases like SLE, RA, and systemic sclerosis. Some of the HLA-B27 seronegative spondyloarthropathies. We've got a case of a 22-year-old man who presents with back pain and stiffness for 3 months. It's not improved following physical therapy. On exam, there's decreased range of motion in the spine and a faint diastolic murmur in the left sternal border, or a aortic regurg. Plain films show a bamboo spine and sacroiliitis. This would be ankylosing spondylitis. You can treat this with indomethacin or TNF-alpha inhibitors. Next is a 34-year-old man who presents with joint pain, difficulty urinating, fevers, and eye pain 3 weeks after a diarrheal illness. His back, left knee, and right wrist are swollen and painful on exam. So this is a polyarthropathy caused by reactive or Reiter's arthritis. It's associated with Salmonella, Shigella, Yersinia, Campylobacter, and chlamydial infections. You can treat this with NSAIDs and immunosuppressant agents. Last, we've got a 29-year-old golfer who presents with stiff and painful hands and shoulders. He has had a history of silver-appearing patches with pinpoint bleeding. On exam, there are fingernail pitting and swollen digits, or sausage fingers, and this is classic of psoriatic arthritis. You can treat with NSAIDs, methotrexate, or TNF-alpha inhibitors. Thinking about hot joints, any man, woman, or child who presents to the ED with a swollen, painful erythematous joint, the next best step is always to do a joint aspiration and a synovial fluid analysis. If the cell count is 50,000 to 100,000 or more, it's more likely a septic joint. If it's between 2,000 and 50,000, you can think of inflammatory things like gout, pseudogout, or RA. And if the cell count is less than 2,000, it's likely osteoarthritis. So we've got a case of a 53-year-old man with a history of diabetes, hypertension, and arthritis presenting for an exquisitely painful foot. He can't even bear to have his sheets touching his toe. On exam, there is calor and erythema around the right MTP. Joint aspiration reveals 38,000 WBCs with a neutrophilic predominance. So this is classic of gout, and you want to look for needle-shaped, negatively birefringent crystals under polarized light. You can treat gout with NSAIDs. You can use colchicine, but you have to watch for GI side effects, and steroids if everything else fails. And you can treat recurrent attacks with diet modification, weight loss, and either propanacid or allopurinol. You do not want to start either of those in the acute phase. Next case is a 68-year-old man with hemochromatosis presenting with acute onset knee pain. On exam, the knee is tender, erythematous, and has a large effusion. Synovial fluid shows 19,000 WBCs with a neutrophilic predominance. The diagnosis here would be pseudogout, and you want to look for weakly positive birefringent rod-shaped and rhomboidal crystals. X-rays may show a chondrocalcinosis, or calcium within the cartilage around the joint. And this is related a lot of the times to gout. It more often presents in the knee or the ankle instead of the foot. Last, we've got a case of a 71-year-old with a history of total knee replacement, and he has knee pain, effusion, and fever. On exam, there is a hot, swollen joint. Synovial fluid shows 123,000 WBCs with greater than 90% neutrophils, and there is gram-positive cocci in clusters. So this is likely a septic joint after a joint replacement, something like staph epidermidis or staph aureus, and you want to treat with a surgical washout, antibiotics, and a spacer placement. Going to the shoulder, we've got a 53-year-old man with a long-standing shoulder pain, worse when he raises his arms above his head. Yesterday he fell on his outstretched hand and aggravated it further. On exam, there's weakness with external rotation, and pain is elicited by shoulder flexion with internal rotation and pronation of the arm, or Neer's test. X-rays show a calcific supraspinatus tendon. So this is a shoulder impingement or rotator cuff tear. The next step would be MRI, and to treat with NSAIDs, physical therapy, and surgery if needed. Next, we've got a 61-year-old man with diabetes who presents with decreased motion and pain in the shoulder. On exam, there's decreased range of active and passive motion with flexion and abduction of the shoulder. This is adhesive capsulitis. You can treat this with physical therapy or manipulation under anesthesia. Next, we've got a case of a 69-year-old man who presents with arm pain and a deformity. He heard a loud pop when he lifted his suitcase at the airport, and there's a visible bulge on exam. This is a biceps rupture. You'd have to treat this surgically. And then last, we've got a 32-year-old who presents following a fall on an outstretched arm. He holds his arm abducted and externally rotated with a visible deformity in the shoulder. This is an anterior dislocation of the shoulder. Posterior dislocations are far less common unless there's a seizure or electrocution, and you want to treat this with reduction. Moving down to the elbow and hand, we've got a 28-year-old G2P1001 woman who works as a secretary, and she presents at 23 weeks gestation with hand pain and tingling. She describes the tingling in her thumb, index, and middle finger, and it worsens at night. On exam, the pain is reproduced with tapping of the median nerve, or Tinel's test. The diagnosis here would be carpal tunnel syndrome. You can confirm it with nerve conduction studies, and you want to treat this with wrist splinting, steroid injections, or a surgical release of the carpal tunnel. Next is a case of a 57-year-old who fell on an outstretched hand and presents with thumb and wrist pain. This pain is elicited when palpation of the anatomical snuff box, and this is classic for a scaphoid fracture. You want to repeat X-ray in 2 to 4 weeks to monitor for avascular necrosis, and you want to treat it with splinting and surgical pinning if that's the case. So a 45-year-old woman presents with increasing wrist pain. She denies any trauma or repetitive movements. On exam, it's elicited by grasping her flexed thumb within the palm, or Finkelstein's test. The diagnosis would be de Quervain's tenosynovitis, and you can treat this with NSAIDs or steroid injection or bracing. Last, we've got a case for a 34-year-old handyman who has elbow pain after his power drill breaks, and he's forced to use a screwdriver. On exam, pain is reproduced with palpation on the lateral condyle and resisted wrist extension. So this is lateral epicondylitis. You can treat this with NSAIDs and rest. It's also called tennis elbow. Going to the back, we've got a 45-year-old man who presents with back pain after a pickup game of rugby. His pain is worse in the morning and improves with head or ice. On exam, there's paraspinal muscle tenderness with a negative straight leg raise. The diagnosis here would be muscle strain or spasm, and you can treat these with NSAIDs, Tylenol, and moderate activity. You don't want to do bed rest for this. Next is a 54-year-old man who presents with back pain after moving his daughter into her college dorm. He felt a pop and has a sharp burning pain shooting down the posterior of his leg. Straight leg raise is positive, and patellar reflexes are +2. So this can be a herniated disc. You can treat this with NSAIDs, Tylenol, and moderate activity as well. Next up, there's a 68-year-old man who presents with increasing back and leg pain with activity. He finds improvement when leaning forward on a shopping cart or going uphill. The diagnosis would be spinal stenosis, or the shopping cart sign. You can confirm with MRI, and you can treat with surgical decompression and physical therapy. Next, we've got a case of a 74-year-old man with a constant aching back pain. It's worsened at night. He has a long history of difficulty urinating with increasing frequency and dribbling. And on exam, there is point tenderness in the sacral area. So there are multiple red flags here, and this is diagnostic for metastatic disease. Next best step would be an MRI or a bone scan, and you can treat the underlying cancer and use steroids for spinal cord compression syndromes. Last, we've got an 82-year-old woman who presents with increasing back pain after she fell over a curb. She has lost height over the past 3 years and has a history of arm and hip fractures. On exam, there is point tenderness of the lumbar spine, and this is an osteoporotic compression fracture. You can confirm it with X-ray or MRI, and you want to treat these with surgical fixation and osteoporosis treatment. Going to the knee, we've got a case of a 21-year-old college soccer player who presents following a non-contact injury in practice. He felt a painful pop and went down, and depending on what you find on exam can lead you towards the answer. If there's laxity with anterior motion of the tibia, like an anterior drawers or a Lachman's test, it's likely an ACL. If there is a painful clicking on external rotation and extension, or a McMurray's test, or unable to fully extend the knee, or feelings of giving way, that's going to be more likely a meniscus tear. If there's laxity with varus stress, it's an LCL. If there's laxity with valgus stress, it's an MCL. Next case, we've got a 36-year-old who presents with increasing knee pain after starting an exercise routine. Pain is reproduced with palpation along the inferior and medial aspect of the tibial tuberosity. This is a pes anserine bursitis. You can treat this with NSAIDs, rest, or a steroid injection. Next case is a 41-year-old who presents with knee pain after retiling his bathroom floor. On exam, there is swelling and pain along the patella. This can be a prepatellar bursitis. You want to treat this with rest, ice, NSAIDs, and maybe a steroid injection. And lastly, there's an 18-year-old woman who presents with knee pain that is worsened when going downhill or upstairs. Pain and crepitus is reproduced with manipulation of the patella with the knee in full extension. This is patellofemoral syndrome. You can treat this with NSAIDs and quadriceps strengthening. Going down to the ankle and foot, we have a case of a 19-year-old woman's cross-country runner who presents with insidious onset of foot pain. On exam, there's focal pain with palpation of the navicular bone, and this is a stress fracture. You can confirm with X-ray or likely MRI. You need to treat with boot and rest. Next case is a 49-year-old who presents with heel pain and burning that is worse when she gets out of bed and after a long commute. This is more likely a plantar fasciitis. You can treat this with rest, ice, and also a boot. And last is a 34-year-old runner who presents with pain at the bottom of her foot. On exam, there is a painful clicking sensation when palpating between the third and fourth metatarsals. So this is a Morton's neuroma. You can treat this with shoe inserts or surgery. Moving on, we've got a case of a 62-year-old man who presents with increasing hat size and decreased hearing. Last year, he suffered an arm fracture after bumping into his counter. On exam, there is frontal bossing, and laboratory evaluation shows an elevated alkaline phosphatase. So the diagnosis would be Paget's disease. X-rays might show osteolytic fractures and a mosaic pattern of bone, and you want to treat with bisphosphonates. Next is a case of a 36-year-old IV drug user who presents with fever, malaise, and back pain. On exam, there's focal tenderness in the spinal processes. ESR is 112, and there's leukocytosis. And this can be an osteomyelitis. The next step would be an MRI and treat with long-term antibiotics after a bone culture. So bone tumors. We've got a 20-year-old man who presents with thigh pain that's worse at night. The pain improves significantly with NSAIDs. X-rays show a small round lucency and a sclerotic margins and central ossification. And this is an osteoid osteoma. You can treat this with NSAIDs and serial X-rays to make sure it resolves. Next is an 18-year-old man with chronic leg pain. On exam, there's a palpable soft tissue mass over the right femur in the mid-shaft area. X-rays show a spiculated or sunburst pattern and periosteal elevation, or Codman's triangle. The diagnosis here would be osteosarcoma. Increasing ESR and ALK-Phos are also seen on labs, and you can treat with surgical resection and chemotherapy. Next is a 28-year-old who presents with pain, swelling, decreased range of motion in the knee. X-rays show expansial and eccentric lytic areas, or a soap bubble appearing, and this can be a giant cell tumor of the bone, and you can treat these with surgical resection and bone grafting. Looking at some films here, in RA, there's osteopenia. If you notice, there's ulnar deviation and degeneration. Next picture is shown as a bamboo spine, or a sclerotic spine of ankylosing spondylitis. Next is a scaphoid fracture, so you have to watch for osteonecrosis. Next is pseudogout due to chondrocalcinosis. So you can see the line between the femur and the tibial condyle. Next is Paget's disease with the classic mosaic pattern of bone and thickening of the skull. Next is an osteoid osteoma, so the central ossification and lucency. Next is an osteosarcoma with the sunburst pattern in Codman's triangle and a giant cell tumor or a very soap bubble appearance. So that finishes up the rheumatology chapter. Next up, we will finish off internal medicine with dermatology and immunology.
I am Professor Patrick.
Professor?
Dr. Professor Patrick.